So today I'll try to go through an update on targeted and immune treatments for lung cancer, a very rapidly evolving area and really interesting times. So I'll go through non-small cell lung cancer targeted therapies, EGFR, ALK, ROS, and BRAF, immune therapies in first-line, pre-treated patients, and very recently stage 3 disease, and briefly talk about small cell lung cancer as well. So when we talk about a target, what do we mean? What is a good target in treating cancer? A good target has two different specifications. One is that it should be able to differentiate the cancer from normal cells. Secondly, it should be essential for the cancer to live. And when we put all of these together, there are multiple differences between normal cells and cancer cells. Probably the most important one is that cancer learns how to sustain its proliferation without a need for constant growth factor signaling. Another topic that we'll touch upon today will be avoiding immune destruction, as in the immunotherapy part of the talk. So when we talk about sustaining proliferative signaling, this includes majority of targets in targeted treatment of non-small cell lung cancer. A good example is EGFR signaling. And as you can see in this example of MAP kinase signaling pathway, the growth factor needs to attach to the receptor. The receptor has a domain inside the cell, which is a tyrosine kinase domain, starts to phosphorylate a cascade of proteins which go down and lead to proliferation. Well, just some simple facts about EGFR mutation, which is one of the more common targets in lung cancer. It is found, depending on the population you look at, has different, you'd find it in 10 to 30% of patients. It's more common in never smokers, adenocarcinomas, female patients, and people with Asian backgrounds. Predominantly, it's in exon 18 and 21. And this is sort of the landmark study by Tony Mock in New England in 2009, which showed using the first generation of TKI inhibitor, gefitinib is superior to carboplatin Taxol, which was the standard in EGFR mutant patients. And when you look at the sort of the mutations, EGFR is a reasonable size of the pie. And since then, there has been multiple studies showing the superiority of EGFR TKI first and second generation over normal cytotoxic chemotherapy. So life was easy. We checked EGFR is there. Yes, give them gefitinib or erlotinib. And then if they progress, well, you have to give them chemotherapy. Then people started looking at this progression, what happens in that progression. And what they realized was majority of cases, despite the progression on the first generation or second generation TKIs, they still are EGFR addicted tumors. And a big proportion of this EGFR target alteration happens with a mutation called T790M. And then we looked at our TKI profile. The first generation TKIs, as you can see in erlotinib and gefitinib, their efficacy to affect T790M mutation was really not there. Second generation, afatinib, was slightly better, but when you look at the third generation, osimertinib, it is quite effective on T790M mutation. It is also effective on EGFR mutations of just the normal mutations that starts the disease, and less efficacy for the wild type receptor, which is important as we go through the studies. And then the thought was, what if we go and check these patients who've progressed, give them either standard of care, which was platinum pemetrexed at the time, or osimertinib as the third generation TKI. This is another study by Tony Mock and others published in New England this year. which is AURA3 study looking at osimertinib versus platinum pemetrexed. This is after progression. And this is the sort of curves that you see. The first one is progression-free survival. As you can see, there is a significant improvement with osimertinib. And not only that, patients with CNS metastases benefit again significantly compared to cytotoxic chemotherapy. And we know that our cytotoxic chemotherapy drugs do not cross the blood-brain barrier easily. And this really will help these patients who will progress in the CNS. And this is the forest plot. When you look at it, everyone is benefiting from using osimertinib instead of chemotherapy. So our algorithm changed a little bit. Now we have to look for T790M mutation, and if it is present, then based on this study, put a patient on osimertinib. Looking for T790M is interesting because you can find it in the tissue. That's the gold standard. You can also find it in the liquid biopsy, which could be blood or urine. The sensitivity is lower, but obviously it is much easier than putting a needle into a lesion. And especially, there might be lesions that do contain this mutation. And if those are not accessible, you might biopsy somewhere else and don't find it. So that goes back to the tumor heterogeneity. And then when we look back at our osimertinib profile, we see that it's quite effective when we use it for normal EGFR mutations. And that brought another study forward, and that is using osimertinib first line, compared with your erlotinib and see what happens. Especially, you know that this drug is crossing your blood-brain barrier easier. And when we did that with the FLORA study, which was again a randomized study, this time first line, of osimertinib versus erlotinib in EGFR mutant patients. Just remember this study, it does not check for T790M patients. These are treatment naive. So majority of them don't have the T790M mutation. Still, you see a significant improvement with osimertinib compared to your standard first generation TKIs, which is your erlotinib and gefitinib. And again, you see a lot of benefit in the CNS. Forest plot, again, everyone is benefiting. So that's how we should be looking in the coming years into treating a patient with EGFR mutation. Well, whether or not using erlotinib or gefitinib in the first line is the right thing to do comes back to accessibility of drugs, but certainly after progression, they need to be checked for actionable mutations such as T790M. And we do have access to osimertinib through access programs, and hopefully that will improve further. At the same time, the field is moving to using osimertinib in first line, and we'll see that in the coming years. Now let's move to the next important driving mutation or rearrangement, better said, in non-small cell lung cancer, and that's ALK rearrangement. The way it works is there's an inversion in chromosome 2 which puts two genes which are not supposed to be attached together close to each other, and that leads to a fusion protein, EML4 ALK, and that fusion protein will go and activate numerous pathways leading to both cell survival, proliferation, and stops the cells from going through apoptosis. Again, more commonly found in younger non-smokers with adenocarcinoma. It's rare to be seen in squamous cell carcinoma. Frequency is around 4%, but if we go through these populations and you have someone who is a never smoker and is EGFR wild type, then your chances of having an ALK rearrangement will go up significantly. Several variants of this rearrangement has been found. The clinical significance is still to be clarified. The first line study that looked at this was Ben Solomon looking at first-line crizotinib, which is a multi-targeted TKI versus chemotherapy in ALK-positive lung cancer. This is a profile study published in 2014 in New England Journal. And in this phase 3 study, they showed that using crizotinib first line is superior to using chemotherapy, so that became the standard of care for these patients at the time. And then next generations of ALK inhibitors came to the field. First line, ceritinib. This is a study published in Lancet very recently, versus platinum-based chemotherapy in advanced ALK rearranged non-small cell lung cancer. This is ASCEND-4. So we are looking at comparing ceritinib versus chemotherapy as they did in the profile study. And again, ceritinib shows activity in first line. And when we look at patients who have progressed on crizotinib and give them ceritinib versus standard of care at the time, which is again chemotherapy, you see that ceritinib has significant activity in patients who have progressed on first-line, first-generation ALK inhibitor crizotinib. Further to that, alectinib is another drug which was studied this time compared to crizotinib, because with the publication of the Solomon study, the standard of care for these patients cannot be chemotherapy anymore. This study looked at alectinib versus crizotinib and again showed improvement. This is ALEX study, published probably in a month or so ago, and showed, again, significant progression-free survival for these patients. And more to that, this time we see a significant improvement in time to CNS progression, because these patients do well, and many of them, what will be their life-limiting sort of event will be CNS metastasis. So these drugs in the new generation of ALK inhibitors do cross the blood-brain barrier and do have an effect on CNS to prevent the disease. Summary, well, ALK rearrangement should really be tested in all non-squamous, non-small cell lung cancers. It improves overall survival and progression-free survival. Crizotinib and ceritinib have been proven to work in first line. Alectinib is better than crizotinib in first-line therapy. And there's another drug, brigatinib, which a phase 2 study showed its efficacy. These can be used as well as alectinib and ceritinib in secondary refractory disease after using crizotinib. We are learning more and more about the differences between these different rearrangements and how to use this and when to use each drug. That will be the topic of further research. So this is how we should be moving forward in the coming year until further studies change this picture. Any patient with ALK-positive disease should start on either crizotinib, ceritinib, or alectinib, preferably ceritinib or alectinib, and upon progression, depending on what they've received, to go on another line of ALK inhibition and potentially further down the track. ROS fusion is a less common driver mutation, and rearrangement is more common in younger patients, never smokers, adenocarcinomas, and high-grade histologies. It is rare, but if you take the EGFR mutation and ALK rearrangements out of your non-smoker population, again, you will be having a higher number. This is an older study, 2014, Shaw, showed that crizotinib is very effective in ROS1 rearranged non-small cell lung cancer when you look at the waterfall plot. And since then, it has been used, although access to the drugs is a bit of a problem, especially in a rare situation like this. BRAF V600E mutation, this is a well-known driver mutation in melanoma and has been worked, many drugs have been sort of tried, and now there are standards of care for BRAF-driven melanoma using a combination of BRAF and MEK inhibitor, dabrafenib, trametinib. This very same combination is approved to be used in BRAF-driven non-small cell lung cancer, and is based on a study by Planchard in Lancet Oncology last year, which showed a significant response rate to this drug. So this is what we have as of now in 2017, how to deal with a mutation-driven non-small cell lung cancer. Now let's move to immunotherapy, which is, in a sense, another targeted treatment. Let's go back to our sort of famous picture. This is a picture from a review done by Weinberg and Hanahan in 2011. They looked at the hallmarks of cancer, and it's probably one of the most cited oncology publications around. So when we look at another side that is important in lung cancer management, avoiding immune destruction. Just going back to the basics of how cancer immunity works, cancer by definition is genetically unstable, which means that mutations happen in these cells, and those mutations translate into new proteins, and those proteins are new antigens. Those antigens will be presented to the immune system, which includes your antigen-presenting cells. They will be processed, they will be presented to your T cells, and the activated T cell goes back, finds the same antigen, destroys the cell. This is a very complex and highly regulated process. You don't want your T cells to be over or under excited by whatever antigen they find. So there are many inhibitory receptors and activating receptors on top of the T cell. We only have had sort of targeted treatments against CTLA-4 and PD-1 and PD-L1 so far. But as you can see, there are many that we know and we don't have a targeted treatment against, and many we don't know. Again, going back to a simplified cartoon of how these signaling pathways work, when we look at your dendritic cell and antigen-presenting cell, the antigen-presenting cell will put the processed, I've got it here, the processed antigen here and presents it to the T cell receptor. In addition to that, there needs to be a second signal. That second signal can be a B7 molecule attached to CD28, means that this cell will be activated. It can be that very same B cell molecule attached to the CTLA-4 molecule on top of the T cell, and that turns this cell off. Now we have an antibody which stops CTLA-4, and that antibody is ipilimumab, which you probably have heard in melanoma patients. Has been around for a while and is the first-in-class drug to be effective in immunotherapy. There's another side to this picture, and that's when the T cell goes and finds the tumor cell. The tumor cell, like any other cell in our body, presents its antigen on top of an MHC class 1 molecule. The T cell receptor recognizes that and says, well, look, this is something that I don't like, and then tries to get rid of that cell. Unless that cell has another signal which negatively affects the T cell, and that can be programmed death ligand, which attaches to the programmed death signal, programmed death molecule on top of the T cell, and that signal activates a cascade which deactivates the T cell. We do have antibodies against PD-1 and PD-L1 nowadays. So let's look at immunotherapy in non-small cell lung cancer first line. This is a study published last year, and it is interesting. This is a study of using pembrolizumab, which is a PD-1 antibody, versus chemotherapy for PD-L1 positive non-small cell lung cancers. PD-L1, as you are aware, will be checked in the pathology specimen, and they defined positive as anything above 50%. These patients were randomized to these two arms, and when we look at it, we see that patients on the pembrolizumab arm have done a lot better than the chemotherapy arm. And the beautiful thing about immunotherapies is that in a small but real proportion of patients, the response will be ongoing because you're using the immune system, and the immune system continues to fight the cancer. It doesn't rely on one target that the cancer cell can change easily. So we're hoping that we see a few sort of ongoing lines on our Kaplan-Meier, and that has been seen in melanoma patients. When we look at our forest plot now, many of these patients do benefit. The lines which sort of when we see a very large confidence interval, it's because the numbers are low in that subpopulation. And aside from that, majority of patients have done better on the pembrolizumab arm. Another study, which is this time a phase 2, but again an interesting study, is a combination of chemotherapy and immunotherapy. So this is the Keynote 21 study, published in Lancet Oncology last year, and they looked at advanced non-squamous cell lung cancer, good performance status, no previous treatments, and these patients did not have any actionable mutations in EGFR ALK. They used pembrolizumab and plus the standard of care at the time, which is carboplatin pemetrexed, compared to carboplatin pemetrexed, followed by either maintenance pemetrexed, which is again standard of care, versus adding pembrolizumab to this. And again, the immunotherapy arm did better, and this was presented in ASCO 2017 this year. The final publication is still awaited. Now, let's take a look at immunotherapy non-small cell lung cancers who've been treated before. One of the first studies to show to prove this concept as a phase 3 study was Checkmate 017. This is squamous cell advanced cancers using either docetaxel in second line versus nivolumab, which is again a PD-1 inhibitor. And as you can see, they did better. Again, we see the tail of the curve is still going. Published in 2015. Very similar study, Checkmate 057, this time in non-squamous carcinomas. Again, there's a survival benefit using the immunotherapy. Later, Keynote 010 using pembrolizumab, another PD-1 inhibitor, again showed improvement compared to docetaxel. The most recent one is atezolizumab, which is a PD-L1 inhibitor, so it works on a different target, and compared to docetaxel, in a phase 3 study recently published in Lancet, showed improvement in both non-squamous and squamous carcinomas with survival benefit. Again, almost everyone benefited, but let's look at the patients with a EGFR and RAS mutation. Some of these patients do not benefit as much, and the idea behind it is some of these tumors, when they're mutation-driven, they may not be as genetically unstable as the others. And the most recent development is immunotherapies in stage 3. And this is a Pacific study, durvalumab, which is another PD-1 inhibitor, compared to placebo as treatment after finishing chemoradiotherapy. So we were involved in this study, and it's an interesting concept. Patients will receive their standard of care, which is chemoradiotherapy. These are non-resectable patients, good performance status. After at least a couple of cycles of platinum-based chemotherapy and radiation, if they did not have progression, they will go into either of these arms. Well-balanced study, and quite significant improvement in progression-free survival in these patients. Again, everyone does benefit, except some of these patients. It could be because the sort of numbers are low. It could be because really these patients are not benefiting. And the reality is that EGFR mutant patients will benefit mostly from our newer EGFR targeting agents. Anti-tumor activity, as you can see in the durvalumab arm, which was the active study arm, patients had more partial responses and less progressive disease. And toxicity-wise, it was quite well tolerated. If you look at your grade 3 and 4 toxicity, which means that this is based on sort of a criteria, simply saying that patients who need a hospital admission or the toxicity affects their activities of personal activities of daily living will be a grade 3. Anything life-threatening would be grade 4. So these patients had around 30, and your placebo arm had around 26% study-related toxicity, which is reasonable because many of these patients, first of all, are not 100% fit. So you see a toxicity and you think it's related to the drug that you don't know is active or placebo. But more importantly, pneumonitis, which was a concern to begin with, at least on paper, because these patients have had recent radiotherapy, and pneumonitis is a known side effect of your immune targeting treatments, was not sort of much different from your placebo arm. So looks like it is safe and, as we saw, is effective. Now let's just briefly go through small cell lung cancer. And this is an interesting study, still phase 1/2 trial, but enough evidence to support the effectiveness of this approach in at least some small cell lung cancer patients. So this is nivolumab alone, which is our PD-1, or nivolumab plus ipilimumab in recurrent small cell lung cancer. Checkmate 32. This combination, again, has been used for a while now in melanoma patients with significant improvements in response rate compared to PD-1 alone treatment, and superior to ipilimumab alone, but is very toxic. Chances of having immune-related significant toxicity is very high with this combination. Preliminary data presented in ASCO again this year has shown promising results, and hopefully this will translate to some improvement in second-line treatment of our small cell lung cancer patients. So immunotherapy in lung cancer, non-small cell lung cancer, first-line PD-L1 positive patients will benefit from pembrolizumab. First-line non-squamous patients will benefit from pembro plus chemotherapy. Pembrolizumab, nivolumab, atezolizumab, and I'm sure this list will keep growing. In previously treated non-small cell lung cancer has showed benefit. A practice-changing study, Pacific study, has shown improvements in after concurrent chemoradiotherapy using immunotherapy, and this is a space to watch in small cell lung cancer. Thank you very much.